have you take it away, Brad.
Thank you, Roberta. Good afternoon, and thank you for joining us in this town hall presentation by Routt County Public Health. I am Brad Boatwright, Executive Director of Casey's Pond, and I would like to thank Roberta Smith, the Director of Public Health, and Dr. Brian Harrington, Routt County Public Health Medical Director. Did I get medical officer? I apologize. Joining us today. And as we see the rise of infections in our area, it is our responsibility to educate residents, staff, families, and we are here to support those with questions related to recent data, as well as vaccine hesitancy. And so we have the experts with us today. And with that, I'd like to turn it over to Roberta.
Great. Thanks, Brad. I really appreciate that. And I really appreciate everyone joining today on a Friday afternoon. And this information is timely, and we've got some data to share with you of what's kind of the current landscape here in Colorado and how we see vaccines playing into that to end our pandemic. I'm going to just do a couple housekeeping things here. I'm going to unmute Dr. Harrington. I'm going to share my screen with our presentation. And Brooke, are we set there? Can you see that?
Yes, I can see your screen.
Okay, and so I'm going to now make you the host, Brooke, and she will have all of the controls here moving forward. And then just again, a reminder, all questions, we will put those into the chat. So again, we wanted to talk to you today just about the benefits of vaccination, how the vaccines work, because we know there are a lot of questions around these vaccines. They're, now we've had them distributed since December of 2020. So they've been out now for over 8 months. And just kind of looking at the data behind that, what the landscape is with our pandemic that we're currently in, and what are the best practices for healthcare personnel, and really what you need to know. So a lot of these slides are taken also from CDC. I will share those with Brad, and these will be available because we do have some links in there that might be helpful to you if you have further questions. But what do we know about COVID-19? Well, COVID-19 is SARS-CoV-2, and this is the virus that causes COVID-19. And we've seen now throughout the pandemic kind of a range of illnesses and symptoms and outcomes due to being infected with COVID-19. Unfortunately, I know we've had some of our residents at Casey's Pond pass, and this is very unfortunate. And we've seen the impacts of COVID-19 in our community. Some people may have had closer relationships to others that have had COVID-19 and have had different perspectives dealing with the virus. But what we know is that this virus doesn't know boundaries. It doesn't know different age groups or ethnicities. It's affecting all of us. And when you are infected, if you are infected with COVID-19, we really don't know how that's going to affect each person, because we all have different immune systems. We all have different vulnerabilities and experiences. What we are seeing is that our older populations, our older adults, and of course those with certain medical conditions can unfortunately suffer some of the hardest consequences with COVID-19. But what we're seeing, and what you've probably heard in the news lately, is there is a new variant, the Delta variant. So I'm not a virologist, so I'm going to throw that out straight away. But with all viruses, they can mutate, and their goal in life is to survive. And so when they see vulnerabilities in our populations, they're going to change and adapt to be able to survive in those new conditions. And what we're seeing is this new variant, the Delta variant, that was first identified in India, is actually a mutation that is now 1.5 times more transmissible than what we saw with our original Wuhan strain that originated back in the end of 2019. So we're seeing increased transmissibility with the Delta variant. We're also seeing increased infectiousness with this Delta variant, and it's really taking a toll on our unvaccinated population, and that's where we're seeing the vulnerabilities. Is this variant is affecting those more severely that have not been vaccinated in our population, and we are seeing some breakthrough. That means if you've been vaccinated and become infected with COVID-19, even though you're fully vaccinated, that's what we call vaccine breakthrough. And we have seen some breakthrough with the Delta variant. However, we do see that the vaccine is protecting well against the Delta variant. And in the next slides here, we'll kind of go over that in detail. And Dr. Harrington, if you want to jump in at any time, you're more than welcome to, if there's other additional information that you would like to add.
Sure.
So this is data we get. Dr. Harrington and I get briefings every week from CDPHE, and some of the slides here are from CDPHE's recent data, and this is the data that they shared with us this week. The lavender kind of coloring in this graph, so the lighter purple, that's the Delta variant. It's also B1617.2. These nomenclatures have changed. WHO has switched to the Greek alphabet. So hopefully we don't get to a point where we have memorized the Greek alphabet with all of the different variants that are going around. But currently the Delta variant is what is accounting for 80% of our cases here in Colorado. So it is now the dominant strain here in Colorado. And like I said, it's a variant that is really not to, I guess, be messed around with. Again, we're seeing more transmissibility and infectiousness with this variant. Many of you may have heard the news of this variant being prominent in Mesa County. We've seen it in Mesa County and also in Moffat counties. And now we've identified more strains here just recently in Routt County. So just to show kind of a little bit of the progression of that, you'll see this is the COVID data that CDPHE puts out. And this is data, I pulled this yesterday, and this is 2-week cumulative incidence data. So these are the past 2 weeks of cases that we've seen in Colorado. You can see hotspots in Mesa, Rio Blanco, and Moffat counties. And you can see Routt County has now turned yellow. We were green for quite some time, which means we've had less than 25 cases per 100,000 for those 2 weeks. And now we're inching up, and hopefully we won't be in the red, but certainly, this, as I mentioned, the virus does not know county borders. So as we see people gathering and going to events, we do see the movement of our cases throughout the county and throughout our Northwest region.
And Roberta, I can add there too. The area of northwestern Colorado, the surrounding areas in Utah and Wyoming are actually one of the hot spots in the country for Delta virus. All of these areas have a higher than kind of average for the US rate of Delta virus infection, which does seem to correlate very strongly with the fact that these areas tend to have lower vaccination rates.
Mhm. Yes. So, what can we do to prevent COVID? So, I think we've all had the messages, last summer, last winter about wearing a mask, avoiding close contact, and washing your hands frequently, cleaning surfaces. But our number one tool, the number one thing that's on the top of the list, is getting vaccinated. And when we had to shut down facilities, when we had to shut down businesses, we did not have this tool of vaccination. And those policies needed to be created because we did not have a tool, we did not have a weapon against COVID-19. And now COVID-19 is a vaccine preventable disease. And this is our number one tool that we can use to prevent the spread of COVID-19. We have a variety of vaccines that are widely available now. At the beginning, we did have, it was very targeted as to who we were rolling vaccines out to, but now anyone 12 and older is eligible for vaccination. We have 3 different types of vaccines. 2 of them are the mRNA vaccine, which we'll talk a little bit more in depth in the next slides here. But the Pfizer and Moderna are the mRNA vaccines. These are 2-dose vaccines with differing intervals, either 3 or 4 weeks, depending. And we also have the Janssen or the Johnson & Johnson vaccine. And this is a one and done. It's a nice, convenient vaccine to just have 1 dose, and that completes your series. After getting both of these doses or your 1 dose of Johnson & Johnson, it's 2 weeks after that last dose or the first dose of Johnson & Johnson that your body actually has full immunity, and we consider you fully vaccinated. So again, we've got all of these vaccines available here in Routt County. We've had the vaccine bus come through and have been providing that. For those that are 12 years of age and older, the Pfizer vaccine is the only vaccine that is approved in that age group currently. So how do mRNA vaccines work? Well, this is a technology that's been used and studied for years. And this is the first time that we've seen this roll out, and there's a lot of benefits to why we're using mRNA vaccines in this situation. A lot of it is the ability to mass produce and get these vaccines out quickly because we needed to do that. Looking at how these vaccines work, I like to use the analogy of maybe a spy movie where someone receives a message, and once you receive the message will then blow up. And this is kind of loosely how the mRNA vaccines work. And once the vaccine is delivered, the mRNA is a messenger, and that's what the M is for. And it tells our cells how to create a harmless protein that will act against the spike protein that is on the SARS-CoV-2 virus. So all of those pictures we've seen now of COVID with the spikes and the crowns, that is the spike protein that this vaccine is targeting and helping your body to create the protection against that spike protein. So once this protein is made by your immune system, then the cell will break down those instructions or the message RNA, and that leaves your body. So then your immune system can use that ability and that coding for that spike protein to then respond if you are exposed to the COVID-19 or SARS-CoV-2 virus. So the mRNA viruses don't use live viruses. There are some vaccines that we have in our adult and childhood schedules that are attenuated live virus vaccines. This technology does not use any part of the virus, so they cannot cause someone to have COVID-19, and you cannot test positive for COVID-19 because you've been vaccinated. The mRNA vaccines do not affect or interact with our DNA in any way. And as I mentioned previously, these vaccines, although this is the biggest mass production of mRNA vaccines, this technology has been studied and developed for influenza vaccines, Zika vaccines, rabies vaccines, and cytomegalovirus or CMV vaccines. And we'll talk a little bit more about that development. I've got a nice little timeline that kind of shows research and development into vaccines and how this existing knowledge and technology and looking at these mRNA vaccines were really the benchmark and the jumping off point to the development of our current mRNA vaccines.
I know some of my patients have found it helpful to understand that this messenger RNA, that the molecules are highly unstable. That's why they actually have to be deep frozen down to like minus 70 degrees for the Pfizer. Once it gets into the body, it is very unstable and doesn't last very long.
So the other technology, and this is the technology that's used with the Johnson & Johnson or Janssen vaccines, this is called a viral vector vaccines and delivery. And I kind of akin this to the Trojan horse. So, hiding bits of the coding in another entity and entering the body and then releasing the information. So these vaccines use a weakened or inactivated form of a virus. So the current one that they're using in this technology is adenovirus, and it, again, cannot cause illness. It's attenuated. It doesn't pose a threat to causing illness in people that get the vaccine, and it is then using the coding. So the adenovirus has the code for the the COVID protein within it. And once that is in your system, then that code is then released, and you have that triggers the immune system to produce antibodies against the spike protein. So a little bit different form of vaccine, but offering, the same response from the immune system through delivery. I have a link on here that has a really good video. In the interest of time, I'm not showing the video, but it really goes through, the activation and how these viral vectors work in their delivery. So we get this question all the time. How are these vaccines developed so fast and brought to market so fast? And really, we have science to thank for this. And if you think about, if you're cleaning a large house and you need to get the job done quickly, if you have one person cleaning it, it's not as effective as if you had a team of people coming in to clean that house. And that's really what happened with developing these vaccines. We were able to put a lot of resources, a lot of scientists, to focus on the development of this vaccine and really have this technology developed very, very quickly. What was beneficial is, and maybe I say beneficial in a good and a bad sense. So back in 2003, you may remember, we had SARS original, and that was just the SARS-CoV. It was the, I guess it's the parent to this virus, SARS-CoV-2. And at that time, when we saw that affecting healthcare facilities, we saw outbreaks of SARS in Toronto, you may remember, and some international locations. And this is what scientists thought were going to be our next pandemic. And so in that light, they started researching SARS, and then MERS came along. They didn't develop into the pandemic that we thought that they could potentially do, but they started looking at these viruses and started to, what if scenarios, and what if we needed to create a vaccine. So back in 2003 is really when this virus was in the spotlight and studies were started. And because these are very close coronaviruses and different coronavirus strains, scientists were able to build on that existing knowledge and existing technology from 2003 to ramp up and bring back to life the studies that would be needed to really expedite and get a vaccine so that we could get this into arms, get this into the population to help with our current pandemic. So this is just a timeline. This is from a Nature article. The link to the article is here. And I do think it really shows, traditional development of vaccines and all of the studies versus the accelerated vaccine development, where studies were able to be overlapped in the clinical trials to really expedite the delivery of the vaccine. Now, even though it was expedited, this doesn't mean shortcuts were made. All of the studies that needed to happen did happen, and we continue to look at the effects of the vaccine amongst now 1 billion people receiving the vaccine. And we'll talk about what safety monitoring looks like here in a couple of slides. But I just thought this was a really good graphic just to give an overview of what goes into vaccine development and the data that's needed to really make it a safe and effective vaccine for our population.
I would highlight here too that this is describing the American vaccine approval process. Every other country out there has their own approval process. Those often, especially in developed countries, can be similar, but they're independent and have sometimes extra, sometimes less things than ours. And it's interesting that all these other independent countries, through their processes, have come to similar conclusions as our FDA and CDC review of these vaccines.
So in talking about vaccine development, a lot of people are talking about vaccine efficacy. How efficacious are these vaccines? And one thing to understand, and I didn't put the link in here, but if you're interested, I can send you, there's a really good PBS NewsHour YouTube video that talks about how vaccine effectiveness is studied and the different perspectives and the different groups that vaccines are studied in. But essentially, when we look at vaccine effectiveness, what we're wanting to achieve is, first and foremost, especially with our pandemic, we want to prevent deaths in our community. Kind of next on that line, we want to prevent hospitalizations and entry into ICUs. Those were kind of the two really big endpoints when this vaccine first was rolled out, to look at effectiveness. So how effective are these vaccines against, then your different endpoint? So this graphic just kind of shows different endpoints that you can look at when you are assessing vaccine efficacy. So when the vaccines were first rolled out, and they continue to be, all vaccines are effective at preventing serious disease. We have found this to be true. We have found this to be true in light of our Delta variant. And this continues to be studied, and it continues to be looked at on a daily basis. The Pfizer, BioNTech, and the Moderna Again, when you look at these effectiveness numbers, this was against symptomatic COVID-19, so having severe symptoms of COVID-19. So 95 and 94% effective for severe symptoms. And the Janssen or Johnson & Johnson showed 70%, 72% effectiveness against moderate to severe disease and 85% effectiveness in preventing most severe disease. And these were the initial effectiveness numbers that first came out. So now that we've had vaccines in our population here in Colorado, the School of Public Health and CDPHE have been working together to say, hey, what's the vaccine effectiveness here in Colorado now that we've had a large amount of people vaccinated already in Colorado. So this might be a little bit confusing of a graph, but essentially they're looking at the relationship of the percent of the population vaccinated, which is the PPV number, and the percent of cases of COVID-19 that were vaccinated. So when we talk about some of that vaccine breakthrough, that would be the PCV cases. So as you can see, we see a vaccine efficacy, again, in that 90 to 95% range for many of our older populations, and then even in that younger population as well. And then again, a different endpoint of hospitalizations and looking at the percent of the population that's vaccinated in relationship to the percent of hospitalizations vaccinated. So again, these vaccines are showing high performance in preventing hospitalizations due to COVID-19. So circling back to the safety of vaccines, and this again is a question that Dr. Harrington and I get quite frequently. Are these vaccines safe, and how do we know that? Well, when the mRNA vaccines first came out, they had to gather, at least 8 weeks of safety data to look at post-vaccination. Were there any adverse reactions events post-vaccinations? If you look at historically at other vaccines that we've had on the market for adults and for children, if you're going to see any long-term side effects due to vaccination, those will occur within 8 weeks of vaccine administration. So that is why the time frame for studying the vaccines gave that 8-week window of safety data that they needed to go ahead with the approval of the vaccines. So there were no significant safety concerns, and we have robust systems in place through CDC, through FDA. Other countries, the EU, the WHO, all have monitoring systems that look at any kind of adverse event that might be reported after vaccination. And those incidents can be reported to those systems. A lot of times, the physician, the person who administered the vaccine, can report to those systems, as well as the person that experienced the symptoms or the potential adverse event can report to those systems. So you can imagine there's a lot of data that is coming in, and that data is being looked at. Most recently, you may have heard with the Johnson & Johnson vaccine, there was actually a pause on the vaccine because 8 cases of rare clotting events were captured. And this was in a sea of over, at that time, 7 million doses of vaccines in the United States had been administered. And so they did find a needle in the haystack, and were able to, within this broad scope of data collection, find 8 cases of a rare event that they were associating with different risk factors of the population. So it tells us that we've got robust systems in place that are continuously being used and are continuously looking for any adverse events. And if there is a situation that needs to be looked at, they will pause vaccinations like they did with Johnson & Johnson and look at the data a little bit more deeply, and then decide, what might needs to change in those recommendations. And in this case, they found that these vaccines continue to be safe, and they were able to update some of the FDA and EUA guidance based on the information that they found. So again, going back to the fast tracking of the vaccines, and just reiterating that when you take resources and you focus it all on one goal, this is what's going to make data very robust. It's going to make the data being produced faster. mRNA vaccines are, I hope to see actually this technology being used for some of our other routine vaccines like influenza, because they are a lot easier to produce in large amounts. If you think about it, when we were doing influenza pandemic planning at CDPHE several years ago, the influenza vaccine, to produce that, you need eggs to produce some of these vaccines. So the government actually had its own chicken flock that was ready to produce eggs should we need a pandemic vaccine for influenza. And, it's a chicken and egg thing. Sometimes you might not have enough, or the virus might not grow in the eggs. So that technology can be very clunky, and using this mRNA vaccine technology really helps in producing large amounts of vaccines in a shortened time frame, as opposed to what we see with traditional vaccines. So before authorization of these vaccines, again, to reiterate, these vaccines have the same safety standards as all of the vaccines that we see in our adult and childhood schedules. The FDA has reviewed all of the clinical information. We've got the ACIP, which is the Advisory Committee on Immunization Practices, which is a branch of CDC. These are a diverse set of specialists who come together to evaluate the data that is being studied around vaccines, and they make all of the recommendations on safety use and recommended use of the vaccines. And some people may have not been familiar with ACIP previously. It's been around for decades, and some of those meetings do get attention, and probably we've heard about ACIP in the news, but they work in conjunction with FDA and really make sure that all of the data is being considered and recommendations are based on that safety data. And as I mentioned, after vaccine, there are tracking mechanisms. We'll talk about vSafe and those apps that are currently being used by CDC to monitor vaccine safety and side effects. But I wanted to illustrate, this is the magnitude. So this was from July 7th. The New York Times has a really great interactive section on their website that you can go and look at vaccine distribution, data maps. And this shows worldwide how many of the COVID-19 vaccinations have been distributed. 3.32 billion vaccines have been administered across the globe. That's pretty impressive. So in light of our over 3 billion vaccines being distributed, there's many systems, like I mentioned, that are monitoring vaccine safety. The existing systems listed here are all available. These are links to their websites. And there is a vSafe app that you can also download from your phone. I downloaded it after I was vaccinated, and this is a way that you can report directly to CDC how you're feeling after the vaccine, if you've had any issues with the vaccine. Frankly, this application would text me on a daily basis at the beginning, and then it moves to a weekly and a monthly basis. And I kind of felt lonely after it stopped texting me, because I was waiting at 3 o'clock for my daily health check-in. Like, someone was actually, asking how I was doing every day. And it was a great way to, report my symptoms. And if they need to, CDC will follow up on the information that you enter into the app, just to make sure that everything is okay. And also it will give reminders for your second dose if you're getting a 2-dose series. So again, COVID-19 vaccination, it will protect you against COVID-19. It will help create an immune response that will help protect you against being infected from COVID-19. It will also protect your coworkers, your families. There's many that can't be vaccinated. We've got a whole population of children 0 to 12 years of age that are 0 to 11 years of age that can't be vaccinated yet. And if those of us who are eligible for vaccination, the more people we can get vaccinated, the better it protects these vulnerable populations, and also vulnerable populations where maybe someone's gotten vaccinated, but they may have a more weakened immune system and may still be susceptible to COVID-19 infection. So the next slides here are just some of the facts. And, these are great takeaways if you need to talk to someone about COVID-19 vaccines. Some of these facts are just very straightforward. As we talked about, the COVID-19 mRNA vaccines cannot give you COVID-19. There's no piece of the virus that is in the vaccine that can cause disease. It just creates immunity after vaccination. The COVID-19 mRNA vaccines will not cause you to test positive on a COVID-19 viral test, nor will the viral vector vaccines, the Johnson & Johnson vaccine. None of these vaccines will have a positive COVID-19 test result. So if you do have a positive COVID-19 test result after vaccination, you probably have COVID-19. And again, it does take 2 weeks after your complete series to realize full immunity. So there is still a window of time, perhaps in between vaccination series, where you are still susceptible to COVID-19. And this is why, you should be continuing to wear masks until you are fully immune through vaccination.
And I'll just highlight that distinction there, that the COVID PCR and antigen tests detect particles of the virus. That's different from the antibody tests. So if you ever had a previous exposure to COVID-19, you can have a positive antibody test. And there are different antibody tests. So we don't recommend this, but if you happen to get an antibody test, understand that some antibody tests are checking for antibodies that are not promoted by the vaccine. So you may get the vaccination, and if you have one of those other tests, it may turn out negative. It doesn't mean anything about your vaccination.
Mm-hmm. Great. And this is something that, again, Dr. Harrington and I field a lot of questions on too. we'll have people say, well, I had COVID-19. I don't need to be vaccinated. Well, we're still looking at how long people are immune after natural infection with COVID-19. That immunity is proposed to be maybe within, 3 months of having that infection, and that immunity wanes over time. So you do need a vaccine to boost that immunity. We're seeing longer immunity being provided through vaccination over natural infection. And there isn't a waiting time after being positive for COVID-19. So if you are infected with COVID-19, you've got your 10-day isolation period. So we wouldn't want you coming out of isolation, of course, during that time. But once that 10-day isolation is over, you're eligible to go and get your COVID-19 vaccination. And that is going to help boost that immunity and make that immunity even longer lasting.
That's what the research is suggesting, that the vaccine actually gives a higher antibody level than a single infection from COVID-19.
Mm-hmm. Yeah, and the jury's still out too about how natural infection plays with the Delta variant and some of the variants.
That too.
So CDC, it has a wealth of resources if you are curious or have needs for other information or want to share information with others. Routt County Public Health, on our website, we do have links to a lot of information. Again, I will send this information to Brad as well, so you can click on some of the videos and the information we have posted in this presentation. But now I'd really like it to open it up to everyone here and see if you have any questions that Dr. Harrington and I can address. And Brooke is going to be our facilitator for those questions. So please just put those into the chat and we will read those off and answer them.
In case you're not super familiar with Zoom, there's a little chat button down on the bottom next to your video and mute buttons. So if you click that, it'll open up the chat for you to start typing in. I do not yet see any questions. We have a very quiet group besides the fact that we have muted everybody.
Everyone.
Looks like Chuck has a question. Chuck, how's your sign language?
Oh. Here, let me unmute you for a second, Chuck.
How's that?
There you go.
Perfect, I can hear you.
You know, I'm interested in the unvaccinated and how it relates to the percentage of the people that have already developed an immunity through having the COVID. Is there any guess as to how that might be? And that might tell me, along with those that are vaccinated and those that have already had the disease, what percentage of the population would that be? I mean, it's probably a number nobody can come to, but has anybody ever estimated it?
Well, actually, yes. I mean, there's different ways of kind of deriving or guessing at a number. You know, throughout the pandemic, at various times, there's been antibody assays done of select populations, and they'll find that in a given maybe 5% or 15% of the people actually have antibodies suggesting a previous, response to an infection. In some communities that had high rates, such as New York City, places like that, in some boroughs, they found over 20% of the people had antibodies. But through most of the US, the antibody presence really runs in the 5 to 10% range. And then kind of to a previous point, we have debate about, well, okay, what does that mean? We don't know what level means what degree of immunity, how long it really lasts. I have used a rough estimate, assuming that on top of our vaccination rate in our community, we probably have an extra 5 to 10% of the population that have a degree of immunity related to previous infection, and they've chosen not to get immunized. That's a guess, but currently that number is above 0, and it's on to our herd immunity in our population.
Mhm.
And just to add to that, that is part of the data that is shared in some of the modeling data that comes from the School of Public Health and CDPHE. And I just flipped through as Dr. Harrington was talking. And as of 6/28, so June 28th of this year, approximately 54% of Coloradans are immune to SARS-CoV-2, and that's through vaccination or prior infection.
Also kind of related to that, we see, this concept of breakthrough infections. We have seen several people in our county who had COVID sometime, say last year or this winter, who then got it again. Now, in all those cases, their second round tended to be a mild case, but it's very clear to us that if you've had COVID before, you can get it again. And anecdotally, Roberta, you correct me on this, but it certainly seems that these cases of breakthrough infection on people with previous infections are cropping up certainly before 6 months, kind of to some of the research data suggesting if you've had COVID previously, that your immunity from that is not guaranteed to last too long.
Mm-hmm. Yeah.
Katie has a question about booster shots. Would it be the same mRNA vaccine that you got previously? And if we don't know if there needs to be one, why do we need to be concerned?
Mir, you first, Roberta. I'll go ahead and start out. I would bet that we'll get a booster shot, but I would not bet a lot of money. I'll bet $20. There's 2 things that will play into determining the need for a booster shot. One, as we've discussed, is how long does immunity last, either from an infection, for example, or from a previous vaccination. Is this a measles type thing? Because we've all been vaccinated for measles, and that's a one and done thing. You get a vaccination for measles, it's a lifetime immunity. However, tetanus, you have to get a booster every 5 to 10 years. We don't know yet how long our immunity lasts. So that's part of the question out there. The second aspect is this issue of variants. How much does the virus change? And this becomes more of a flu-like question then, because like with influenza, it changes enough each year that you have to have a new vaccine. So far, the jury is out on that. Our current vaccines are continuing to prove very good coverage for all the variants that are out there so far, although to some varying degrees. So that question will need to be answered, and that's the 2-part analysis of deciding if and when we need a booster shot.
I do not see any other questions in the chat.
And I would add a comment about, kind of this, well, the idea that this is a collective issue. You get the virus from somewhere. You get it from somebody with the disease. And we've seen throughout this pandemic that that's the story that comes out is, okay, Bob has COVID-19, he got it from Frank. And, it's often very easy to show that linear connection. It's the same thing we see with our vulnerable patients and vulnerable populations. If we have a population like Casey's Pond who is not leaving the building much, then their main exposure is it's getting brought into them. And that highlights the need for all of us, because I do my rounds over there and stuff. That highlights the need for all of us to help protect those people. And so it becomes not just an issue of, what am I doing for myself, but it's an issue of what am I doing to protect the vulnerable people in the places where I go. And it's kind of become an extra issue for vulnerable groups such as skilled nursing facilities, jails is another example where this comes up. Some of our other group home situations locally and in the state.
Mm-hmm. Yeah, and I think, kind of going back to vulnerable populations, as we mentioned with the vaccines, those that are under the age of 12 can't be vaccinated. And just recently here in Routt County, we've had 3 child care facilities be affected by this, and kids not being able to now go to their daycares because they've had so many cases. They're shutting down. And this, is another vulnerable population. So if we can create immunity even within our households, when we have populations that can't be vaccinated, that does help to reduce transmission. This was a concept that has been used with pertussis. So when you have newborns and you've got families that could potentially be bringing pertussis into the family, it's recommended that adults be vaccinated with those booster doses to do we call it cocooning effect for the child. So I think similar concepts can be done here with COVID-19, and until those vaccines are approved for lower age groups, that's one of the tools that we have, and also to protect, because we're seeing this highly transmissible Delta variant in our community.
So we're seeing a large number of healthcare providers announcing plans to mandate the vaccine, including locally UC Health. Is it fair to say we're expecting to see this trend grow with more employers mandating vaccines for employees?
Mm-hmm. I do believe so. A lot of companies, even the EEOC has put out information for employees to navigate this. It's a matter of time. And, it's very similar to, for me, given I was doing infection prevention at Children's Hospital for many years, and this was before the influenza mandate came out. And we had seen a patient die of influenza, and this patient, unfortunately, was a child that had, for 1 year, no visitors. And it was all staff that had interactions with this child, and that is how influenza was brought in, was from a staff member, and that's really what instigated that mandatory program. And as we see vulnerabilities, as we know that there is a tool to prevent COVID-19 and a tool to protect our vulnerable populations, we have to use this tool. And we will see employers not wanting to shut down as well, like even private industry where you don't have vulnerable populations. A lot of them know that if they have a highly vaccinated staff, they're not going to have to shut down, and that is, beneficial to them and the clients that they serve. So in healthcare, where we have vulnerable populations, we also want to protect the worker, and workers are at risk. And every day, when nurses and physicians and MAs and CNAs and LPNs go on the job, you're putting yourself at risk. And so even OSHA is on board with vaccinations. OSHA mandates hepatitis B vaccinations for bloodborne pathogens. So there are groups not only protecting patients, but protecting workers that have put out guidance helping to facilitate this move. And it's a matter of people putting in the policies in place that address all of the different aspects that could be encountered, and having a plan to, be able to respond to different situations accordingly. But I do see that movement growing, and also, incentives as well. We've seen some companies do that.
Yeah, it doesn't surprise me in the least. I mean, it's an old concept. Healthcare, for example, has long had examples of vaccine requirements for influenza, hepatitis B. Schools have used it for a long time, vaccine requirements. you have to have yellow fever or varicella immunizations to travel to some foreign countries. We've seen some businesses in the past require vaccines in certain situations too. So it's an old concept, but I think we're seeing how it's kind of going to grow rapidly here in the United States with a vaccine that's highly effective and highly safe in a disease that's so dangerous.
So we do have a few questions in the chat, and we're going to let Brad address those directly.
Well, there was a previous question back too that I'm going to jump in just to touch on because I don't think we quite answered it on the booster issue. And that is, if there is a booster, what would it be? We don't know yet. They are manufacturing though, the mRNA technology makes it so easy to kind of change what it covers. So that could very well be the one we see. And as you heard, there's even announcements that Pfizer's working on it and Moderna's working on it. But all the types of vaccines are likely in future production runs to make changes in it if needed. But at this point, I can't promise which type of vaccine will be the booster. We don't know yet, for example, if you had the Pfizer vaccine, did you get the Johnson & Johnson for a booster or whatever? That's all down. We don't know any of that yet.
And I apologize, I cannot, okay, I was able to see the previous question. Question, wondering if there will be a portion of today's program that addresses what's actionable now at Casey's Pond. At this point, what we've been doing is meeting with residents, staff, and getting feedback on what they want to see in their community, right? This is the residents' community. We are here to speak and advocate for the residents in their home. And at this point, we have had almost 100% of residents that have taken the vaccine, and they obviously have been unanimous in wanting to see Casey's Pond go down the road of investigating and possibly implementing a mandate for the vaccine. And we understand the concerns. It is difficult when you look at 100% of the residents in a community asking for this and to kick that can down the road, for lack of a better term, because I know that we talk about the trends, we see the trends. We know organizations want to mandate after this FDA approval. And, we look at that and it's our understanding, most of this is just formal paperwork moving through a system, right?
Yeah.
FDA is not continuing to trials and possibly just say we're not going to support this, correct? So when we look at it and we've had discussions, people are asking, why would we slow down this process to hold on for paperwork to move through, a government agency, when we look at the trends and the numbers that directly say that we're seeing a growth in infections here, and we have to take that very seriously. And it is what the residents and most staff have said that as well, and they support seeing us considering that mandate. So what's actionable now at Casey's Pond is we're still just investigating, gathering questions. We want to make sure that people understand what this means, why we're doing it. And that's the point of today, is making sure that we can get that information to them so we can make a better decision on when and how that might look. So it has just been an active participation with everybody in the community.
And I'm sensing a tipping point actually amongst some of my patients who I talk with who continue to maybe have some vaccine hesitancy. Here we are, the first vaccines were administered back in September. We're approaching a year with these vaccines. The numbers that Roberta showed, 300 million doses in the US alone. I'm not sure what other number we're going to wait for at this point. The EUA is being lifted. The Delta virus has kind of confirmed that even with, getting rising vaccination rates, there's still risk out there for people who are unvaccinated. We still see people die and so forth. So I've sensed in conversations with patients, that kind of information has been very helpful as they reach a point where level is such that they are choosing now to get vaccinated.
I had another question directed to Casey's Pond. With the labor shortage in our area, if Casey's Pond initiates a mandatory vaccine program for all employees, what percentage of current employees do you anticipate will not comply? And what kind of impact will that have on the operation as it relates to timely care of residents? That was an excellent question. I wish we had a hard and fast number. Right now, our vaccination percentage for 2 doses fully vaccinated is around 67% of staff. So we have to then extrapolate out how many of those staff members are actually full-time or part-time staff members. We have a number of people that are in college and only work in the winter season, and that still counts as your employee count. So once we remove that, we start looking at who has a qualification possibly for a religious exemption or a medical exemption, because there is no mandate that would override the rights of the person if there is a medical exemption. So you start to whittle that down, and what starts to seem as a very large number of people, because you've got 33% unvaccinated, it quickly starts to reduce down, and it could be 5, could be 10 people. We just don't know. We feel like as long as we give everybody the support and education they need, we would hope to see that be very minimal. But since we've even talked about it, we've seen multiple team members come off the fence like, okay, it's time. It's time. So it's very difficult to answer. One thing I can share is that as we've talked about this with the state, CPHE has reached out to offer staffing support if there is a major staffing impact because of this. So they would be there with supplementary staff as well.
Great. Brooke, is that, are we at the end of our questions? Did we get everything covered?
Yes, I do not see any more questions.
Great. Awesome. Well, we're kind of at our time here. I just wanted to thank everyone today for your attention, for your participation. These are great questions. Happy to keep the conversation going. You can reach out to myself anytime here at Routt County. Happy to come back and talk to staff. We've recorded today's session, so I will send that to Brad for distribution along with a copy of the slide deck. Again, we are thrilled that we've had such a good response to COVID-19 vaccines here in Routt County as a community. We are, amongst the highest counties vaccinated, but we can do better. I'm not a competitive person at all, but Summit County and other counties are beating us, and we can raise the bar, and we need to make sure that not only are we protecting everyone within our communities, but that we are protecting our vulnerable populations, and most importantly, ourselves.
Thank you, Roberta. Thank you, Dr. Harrington. Appreciate your time today. And if we get any more questions in after this, I'll make sure to get those to you and get answers back to anybody that would like to talk more.
Great. Thanks again, everyone.
All right. Take care, everybody. Have a good weekend.